where you get pressure on the chest wall, prevents expansion. So this can often put pressure on the heart, the blood backs up into the veins, the heart, because of the pressure, just can't move like it's supposed to. You may see this in avalanche burial victims where they've got a lot of snow or weight upon their chest. It can also happen if there's massive rib cage fractures. The chest can't expand like it normally does because it doesn't have the function of the ribs and the muscles between it. You may see ruptured blood vessels in their face, their neck, their eyes, which cause a lot of discoloration with this. And airway is obviously the main thing to evaluate and control in this setting. With chest trauma, be aware that altitude, you can get them lower, the better. Sometimes a helicopter may be contraindicated just because the helicopter has to fly higher. You're not going to make that call. The helicopter can make that call when they get there if they need to. So you make the normal call you would to get the helicopter or ambulance there. How do we assess patients with chest trauma? The same as you do your normal assessment. So you go through your scene size up, scene safety, go through your primary assessment where you're protecting the life-threatening injuries as you go, as you work through your ABCDs. So you're checking your C-spine and circulation and for any disability. You move into your secondary assessment after you've taken care of that part. Reassess vital signs, continue to focus on the ABCDs as you go. Look at the level of responsiveness, your CMS, and document any changes. Go through your DCAP BTLS, so you're looking and feeling for any deformities, crepitus and contusion, abrasions or avulsions, looking for punctures, looking for burns and bruising, any tenderness or temperature changes, lacerations, and swelling and symmetry. If they're alert and responsive, you go through your sample. So you're getting the signs and symptoms that they complain of, ask if they have any allergies, what medications they take, a brief past medical history, when they last ate, and if they remember the events leading up to the injury. And as always, transport is the goal is to get them down as fast as possible. Especially with ski trauma, it's important to evaluate and be aware of the upper back, the armpits, and evaluate all of the chest itself. This can be hard because a lot of people are wearing multiple layers of clothing, so oftentimes we're pushing, we're palpating. If you're able to take a quick look, lift the shirt up, you can. Make sure with chest injuries, you look at the skin and specifically the neck veins, the jugular vein distension, the trachea deviation, things like that. See how the patient is splitting themselves. Are they self-splinting for a rib injury? If breathing's a concern, that's your first focus. Suspend the secondary exam, support that, and transport as quickly as you can when the sled's available. The usual order of things is to look, auscultate, and palpate. Oftentimes on the hill, you're not auscultating. We're not taking out a stethoscope when it's snowing and there's a storm and you're in the middle. You're just trying to transport them. You can look as best you can. As I said, they're often wearing clothes, so that might be limited, but you can push around and see if there's an area that hurts them. And if you're able to lift or if there's something that's concerning, cut open the clothing so you can look at it. The auscultate, not so often do we do that on the hill. How do we manage these chest wounds? With chest trauma, if it's more severe, you're going to load and go and get them going to a higher level of care as soon as possible. If they're unresponsive, no breathing, no pulse, you start CPR. You can use an AED as quickly as you can. Always, always monitor the airway, get the oxygen going, assist ventilations if you need to. Remember again, if they're worsening as you're doing ventilations to help them, it may be a tension pneumothorax. Pay attention to spinal injuries, use the backboard where you need to. The backboard can also come in handy if you need to do CPR and someone's not on a firm surface. Get a backboard underneath them. Control bleeding in its usual manner. And again, most importantly, high flow oxygen transport and get them to the higher level of care. With the sucking chest wounds, this is where you use the occlusive dressing. So you have a Vaseline gauze, some type of chest seal, plastic wrap, a bag, aluminum, some wrapper that you have from a Cliff Bar, whatever, anything you can put on there, and you tape this one down on 3 sides. By doing the 3 sides, this allows, with breathing in, inspiration, prevents any extra air from going inside the chest cavity. But when they breathe out, it allows any of that trapped air to get out. Splint any flail chest segments. The patient may be self-splinting. You can do your best to support that. Again, if there's impaled objects, leave those in place. You can wrap a blanket around them, try to stabilize them, but you just leave them where they are. Definitely treat and position for shock, but be aware that you may have to pay attention to their breathing needs, and the breathing needs come first. So before treating for shock, if they need to sit up so they can breathe, leave them sitting up, or leave them head up instead of head down. Moving on to non-traumatic cardiac events. In general, cardiac chest pain usually comes from ischemia. It comes from decreased blood flow to one or more parts of the heart. And if that blood flow is not restored, the tissue dies. Progression of cardiac vessel disease, it starts with atherosclerosis. This is where you get buildup of calcium and cholesterol inside the vessel walls that create plaque. As that plaque starts to slow down the flow of blood or decrease blood flow, people can get what's called angina pectoris. So this is a pain that occurs when the heart tissue does not get enough oxygen just for a brief period of time. Sclerosis, it sometimes can be a symptom of muscle spasm. Most people describe it the same kind of a crushing, squeezing feeling, someone sitting on my chest. And the thing to be aware of with this is it can affect the electrical system. So there's risk for weird heart rhythms or arrhythmias. Acute myocardial infarction is where you get actual death of the cells in the area where the blood flow is obstructed. The pain with this differs because it may or may not be associated with exertion. It can occur anytime. It doesn't typically resolve in just a few minutes. It'll last for 30 minutes or even several hours. And it may or may not be relieved with nitroglycerin or rest. Typically, angina pectoris is the opposite of that. With the acute myocardial infarction, most times people again describe it as a crushing chest feeling, heavy chest, someone sitting on my chest. It can also radiate up into the jaw, the neck, typically the left arm or shoulder, sometimes to the back. You may feel or look anxious. They may say they're dizzy, nauseous. They may be diaphoretic, often have this sense of impending doom. Be aware that silent MI. So they may just feel kind of tired or a little short of breath, more likely to have the back pain, abdominal pain versus that left arm, shoulder pain. They may have some nausea as well. A quick comment on congestive heart failure. Congestive heart failure occurs when the ventricle of the heart muscle is so damaged it can't keep up with the return of the blood flow from the atria. It can't push the blood out through the body. This can occur after myocardial infarction when the tissue is died. It can be from heart valve damage. And when the muscle can't contract effectively, the heart may try other ways to get the blood flow where it needs to go. So people may have, in general, a higher heart rate. The left ventricle can enlarge to create a better pump, and that creates what we call cardiomyopathy or enlarged heart. And how do you approach the patient with chest pain? If the patient's responsive, is the patient responsive first and foremost? If they're not, you call for help, get the AED coming, and start CPR. If they are responsive, then you can go through your general assessment, making sure the scene is safe. You go through your primary assessment and you go through the ABCDs and treat what you need to. As soon as you have oxygen available, get the high flow oxygen on. Often these patients are going to be more comfortable sitting, so put them in a comfortable position and make sure they're well supported. The one thing to realize, if they have chest discomfort, they can go into cardiac arrest at any time. You don't want them falling and having a head injury on top of everything else, but be watching for that and happened. Always important to pay attention to vital signs in these patients, repeat those regularly, and make sure you monitor the vital signs. Go to your focus history, go through your sample, go through the OPQRST, and with that, specifically focus on pre-existing heart conditions. If they have them, if there's medications they take related to their heart condition, ask about what the chest discomfort is like and do a focused exam. If they have nitroglycerin, or following protocols for us, you would administer nitroglycerin and then administer aspirin. With any type of chest discomfort, it's really important and critical to transport quickly. And as you're transporting, report to medical control. A quick review, we talked about this last doses, milligrams, which is 1 tablet. You give 1 every 5 minutes up to 3 doses until the pain is relieved. Contraindications for nitro include hypertension, where the systolic blood pressure, hypotension, that should say, where the systolic blood pressure is less than 100 millimeters of hemoglobin. If they have a head injury or bleeding risk, we don't give nitro to infants or children. They typically consider children less than 15 years of age. If they've recently in the past 72 hours taken an erectile dysfunction drug such as Cialis or Viagra, they may often refer to it as the little blue pill. And then always check expiration with medication. To help patients, you assess the patient, evaluate for contraindications, make sure they have an airway to be able to give them, and make sure it's the right patient name and check expiration, whether it's their supply or from the patrols. Use gloves. Oftentimes the nitro can kind of get in your skin and give you a headache. Place the tablet in the patient's hand and have them put it under their tongue. Remind them that they are not to swallow it. Allow it to dissolve under the tongue. Monitor their blood pressure every 2 minutes to make sure it stays above 100 millimeters of hemoglobin for the systolic blood pressure. Main side effects with nitro, they may get some burning under the tongue as it dissolves. Most frequently, it's a headache. If they have their own supply, they often know this, but remind them. And once you give that, it's still really important to transport as quickly as possible, even if they experience relief in chest pain. Always document the patient name, date given, time given of each dose, and why you gave it. With aspirin, the dosage for aspirin is 325 milligrams, or you give 4 of the 81 milligrams chewed before swallowed. Contraindications, if they have a known allergy to aspirin, if they've already taken 325 milligrams of aspirin within 60 minutes, if they have high blood pressure over 180 over 110, if they know that they have an active GI bleed, and again, monitoring the airway, if they can't swallow, don't give it. Check the expiration, place the aspirin in patient's hand. Once again, with chest discomfort, our goal is to transport quickly to a higher level of care, document the patient name, date given, time given, and why. And then one thing to note is if the patient has nitro, or if you're using the patrol supply, you give the nitro before the aspirin. And I'll run through kind of a quick review of CPR. You guys go through a full course, so this is by no means your BLS review. But the newest guidelines were updated in 2020, so pretty recently. They continue. With advanced airways, they've moved to rescue breaths for adults of 1 breath every 6 seconds, which is 10 per minute, and for children, 1 breath every 2 to 3 seconds, which is 20 to 30 a minute. And you continue continuous compressions once they have an airway present. The other thing that they've added is a protocol for naloxone if there's a suspected overdose. I checked with both patrols. There is no naloxone on the hill. Part of it's a cost thing. It's just not available. That would happen when the ambulance or helicopter got there. But just so that you're aware, that is now part of all of the protocols, is to deliver naloxone if you suspect any type of overdose. So for CPR, you're going to go through, you verify the scene safe, check the patient for responsiveness, call on your radio, get backup coming, including the AED. As soon as the AED is there, use it. You'll look for breathing, feel for pulse. You're checking the carotid pulse, no more than 10 seconds, and you check for both simultaneously. If you're not sure that you feel a pulse, you move to CPR. If you think you feel the pulse, then you do the supportive rescue breathing. For CPR, if you start it, you're performing for adults 30 compressions to 2 breaths. As soon as the AED is there, turn it on and put on the pads. As the pads are being put on, you can continue compressions until it clears to check for a rhythm. If it says the rhythm is shockable, clear the patient, deliver the shock, resume your CPR until the next rhythm check. If there's no shock, then you go straight back into CPR for 2 minutes until it reevaluates, and you continue CPR until they're at a higher level of care. For children, it's very similar to adults. Remember that with the 2 rescuers, it moves to a 15 compression to 2 breath ratio. And the other thing to be aware of is you may feel a pulse, but if it's less than 60 beats per minute and they're not breathing, they recommend starting CPR. So again, verify that your scene is safe. You check for responsiveness, shout for help, or you're checking for breathing. If it's a young enough kid, you may need to go more the brachial pulse than the carotid. If you feel like they have a pulse, then you can do your rescue breaths, which for children, again, is 1 breath every 2 to 3 seconds, so 20 to 30 breaths per minute. Or if you're feeling a pulse that's less than 60 with poor signs of perfusion, you then move into CPR as well. For CPR, if it's just you, you start with 30 compressions to 2 breaths. As soon as you have a second rescuer there, then you're moving to 15 compressions to 2 breaths. Once again, once the AED is there, turn it on. Clear the patient, deliver, resume your CPR. If no shock is advised, you go back into CPR and continue till you can get them to a higher level of care. A couple notes with the automated external defibrillators. The AED is meant to recognize rhythms that will respond and require defibrillation. So 150 to 100 beats per minute is recognized as ventricular tachycardia. The most common shockable rhythm is going to be your ventricular fibrillation. Non-shockable rhythms are typically asystole, that's the flat line. Electrical activity is a state of cardiac arrest where you'll see an organized rhythm if you're looking at an EKG strip, but there's no pulse. These are the non-shockable rhythms. For the AED, always turn it on and it'll tell you exactly what to do. Apply the pads. You continue CPR while the pads are being applied, but then stop it while the machine analyzes the rhythm. If the shock's advised, clear the patient, push the shock button. You resume CPR if they're unresponsive, and then you can do supportive breathing, oxygen, and transport if they do become responsive. The key with the AED, couple notes, is to keep it attached. Even if they're responsive, they can go back into cardiac arrest. So do not remove the pads as you're transporting. Recheck the pulse frequently, analyze and resume CPR if you lose the pulse. For safety with the AED, make sure that you're always clearing the patient before shocking. In a pool of water, you don't want to defibrillate, but you can defibrillate if they're wet. They just ask that you dry the chest first. They're in a pool of water, move them out, put them on a backboard, go from there. Do not defibrillate someone who's touching metal that others are touching. So again, that's another thing you're looking for when you're clearing the patient. If they have a nitroglycerin patch or any type of patch or anything like that on their chest, remove it first so that the defibrillation doesn't ignite the patch. The AEDs cannot analyze rhythm while you're in motion. So if you have someone in a sled and you're giving CPR, your options are to stop, analyze, or keep going and analyze when you get to where you're stopping. Most likely the goal is to transport here. So continue compression, ambulance, or down the bottom of the mountain, and then analyze when you get there. The same goes with defibrillation. You do not defibrillate while the patient is moving. I tried to find some information on CPR specific in chest trauma patients. There's lots of gray areas out there and there's really minimal literature on it. What it comes down to is that survival rates are variable, but with chest trauma patients, it is fairly low. But there's still a percentage of these patients that do get resuscitated. Penetrating trauma, gunshot wounds, stabs, things like that, actually have a better outcome than blunt trauma. Asystole has an extremely poor outcome, especially if they have an initial rate less than 40. They do better if their rate's over 40. This is hard. You're not going to see these rhythms. This is more what the AED is picking up. So this doesn't help us when we're out in the field. Unwitnessed has a poorer outcome than if it's witnessed. They do say, however, in an article that I read, that it's reasonable to manage all unwitnessed traumatic arrest patients on scene because you don't know how long they've been down. The main treatment for trauma patients in cardiac arrest is a thoracotomy. This is a surgical procedure that's performed in an emergency department. It is rarely, if ever, performed in an outpatient or pre-hospital setting. So what it comes down to for you as patrollers is to transport the patient to the higher level of care. There's this quote from one of the articles I read says it's reasonable to consider rapid transport in a subset of patients whose etiology and characteristics include witnessed arrest, penetrating trauma of thoracic location, and close 10 to 15 minutes proximity to a trauma center. For us, if someone seems like we might be able to resuscitate them as patrollers, start your CPR and do that. There's obvious cases where patients are already dead when you get there. And if it's that obvious, then you don't need to do CPR. But in most cases, you are going to go ahead and start and do that. Another article I read came to the conclusion that although survival after CPR among trauma patients continues to have dismal outcomes, advanced cardiac life support should be initiated regardless of the initial EKG rhythm, which we don't see that EKG rhythm on the hill. Ultimately, both a rapid response time and transport to the ED are the utmost. Articles trying to find some more information. It doesn't change what you do as patrollers. You initiate CPR if you don't have a pulse and you don't feel that there's breathing in someone who is obviously not already deceased. So just to review what we've talked about tonight, we did a quick anatomy review of the thorax and cardiovascular system. We talked about thoracic trauma, different types, how to assess and manage these. We talked about non-traumatic cardiac conditions and how to assess PD and specifically CPR in chest trauma patients. So before I take questions, there's one little video here that I'll conclude with.
The Snowy Peak Ski Patrol is looking for a few good men. You must be a daring outdoorsman. To maneuver dangerous curves. And always on your feet.
Because it's family life.
All applicants must be willing to relocate. Athletically inclined and level-headed.
What do we think?
I think I want to go home.
You can't do us. We can't take you anywhere.
We'll make some new connections. Meet new friends. And learn some new hot doggers. And ski bums need not apply. So if you're ready to spring into action,
Oh, shit.
there's only one way to the top.
And remember, I'm a professional. Don't try this.
Join Ski Patrol. You'll have to ski it to believe it. Ski Patrol, now available on video cassette.
Any questions?
Looks like there's one question that came up. I'll read it to you, Amy. Oops, let's see here. In regards to CPR, I read that we will continue or start CPR is there any rule regarding the systolic BP for adults?
No, for adults, you either feel a pulse or you don't. And again, with adults, you're more feeling for the carotid. They've looked into even, do we continue checking for a pulse? They found that some people, it's tough to tell. Some people, especially where you're revved up, you actually feel your own pulse, not the patient's. So for adults, there is no guideline like that. Either you feel a pulse or you don't. And that's why they have you recheck periodically. And that's where the AED comes in handy, because it'll tell you or not if they need a shock. But with adults, just with pediatric cases, are we looking at the 60 or less?
And another question right after that is, in pediatric cases and the pulse is like 68, how's the responder to treat the patient?
Yeah, the algorithm. And if you look over where it talks about heart rate less than 60 beats per minute, it also says with signs of poor perfusion. So if you have a child who's talking to you and breathing and their heart rate might just be really low, they have pretty good perfusion. You can feel their hands and fingers. They're responsive. You probably don't want to start CPR in then. If you have a patient who's not responding to you, you feel a pulse that you're not sure, is it greater than 60 or not? That's someone who, if they're unresponsive, their hands and feet, their body's cold, that's where you're looking for perfusion as well. The other thing to be aware of is they don't want you checking for more than 10 seconds. It's really hard to tell. Are they at 68? Are they at 58? A lot of it with the pediatrics, if you feel a pulse and it's just very, very, like maybe you feel 1 or 2 beats and they're unresponsive, poor perfusion, go ahead and start CPR. You're not taking 30 to 60 seconds to get that exact 68 beats per minute.
That's great, Amy. I have a couple comments and a couple questions if no one else does, or while someone else is writing one. First, great slides, wonderful video, and please tell John that he did a good job. If you were taught, my question though is, if one of the patrollers asked, what were the 3 things or a couple things that I would take home, what would you say those would be?
The main things when you look at chest trauma are making sure you do a good assessment and you continue to focus on treating patients how you would with any other patient. It comes back to what they teach with OEC, with the EMT basic, that you in the same manner that you would with any other patient. Be aware of chest trauma patients can be more serious and that internal injuries, you may not realize what's going on. And now those 2 things, so your basic going through how you would assess all patients, be aware that chest trauma patients might be more complicated than you realize and that they can go downhill quickly. And then just a good review with if someone does become unresponsive, being comfortable with CPR and knowing how you
That's really perfect. I would reiterate, we want to be thinking ahead and realizing that we're an urban ski area where if we can get a serious patient, which the patients we're talking about are serious, to a trauma center, we want to do that. So the faster we can recognize things and arrange for transportation while, looking at the movie rather than the snapshot, what's changing and anticipating what could happen next. I think that's what you told us really, really well tonight, and I really appreciate it. If no one else has any other questions.
I think there's one more question here.
Okay.
Anything we do differently if we're treating people for lesser injuries and they say they have fib?
See that one. Oh, there it is. Oh.
Yeah, in someone who has, so say they have atrial fibrillation or an underlying heart rhythm of some type, the main thing to be aware of is what medications they're on. Often with AFib, they may be on a blood thinner, and even in minor injuries, that risk of bleeding may have you transport more quickly or call it to a higher level of emergency than it would be for a normal patient. So that's where, again, going through your sample and making sure you know what meds they're on or what other risk factors they have comes in as being important, even in a minor injury. It may mean that you just transport them a little more quickly or at a higher level of care than you would. And then one more question on how would we continue CPR during transport off the hill? That gets tricky. So on the hill, obviously, I believe you guys still practice in training and maybe during the year of how to do CPR moving in a sled. So either you straddle the patient or you hook 2 sleds together. Those are things you can practice and figure out what's most comfortable if you're doing CPR in the sled. This is where I mentioned getting a backboard underneath at the bottom, and you need to get them in an ambulance. They're not going to take a CPR patient in a helicopter, but getting them to the ambulance with the backboard is going to be easier to carry. That's a time where you're probably not going to continue compressions in that transport. It's a little too hard to carry 2 people on a backboard and continue compressions while that's moving. So there may be a case there where the compressions are discontinued for a short time as you make that transition off of the hill.
Okay, I don't see any more. Do you, Amy?
No.
Yourself if you want and speak, that would be fine too. But if not, we're gonna let everybody go. I'm gonna have Kathleen and Amy stay on for a second, but everyone else go and have dinner or do something fun, and we'll meet again next Wednesday, same time, same station.
Thanks, everyone. Have a great season. Oh, question.
My apologies. Yeah, hi. I had one more quick question before we left.
Well, go for it.
It wasn't exactly on the lines of this, but this conversation kind of brought it up, so I figured I'd ask while we were here. Bleeding, where you need to hold pressure, how is that applied in, how is transport going to work? Are you standing on top of the patient? Are we continuing going down when it's necessary to keep pressure on? How does that look?
And are you referring to pressure for controlling bleeding then?
Yeah.
Yeah,
Mhm.
so that's where you can apply pressure dressings in some way. So a very tight dressing, or in some cases, a tourniquet if you need to. If it's something that somebody can't apply their own pressure, it may mean that you're riding in the sled with someone. So say they have a large abdominal bleed and you can't wrap that
Mhm.
super tight very well. You may have somebody sitting in the sled with the patient. That's the case where maybe the patient's sitting up and you have a patroller sitting behind them holding pressure, or they're laying down and you have a patroller kneeling beside them or over them as you transport. That's, as patrollers, where we get to kind of think out certain airways, breathings, all those type of things in whatever manner we can to transport them to get them off the hill. And a lot of times it's getting creative. But that's a great thing to think about. Maybe come up with some scenarios and practice those when you're on the hill to come up with some ideas as well.
Yeah, absolutely. Cool. That's what I was thinking. And yeah, you've been great. So
Thank
thank
you.
you very much.
I'm going to make one final comment that I should have made before, and that is last year was a very unusual year and a very exciting year in that we had several full saves where someone had a cardiac arrest, and through patrol and other quick action, we were able to not only get them down to the hospital, get them in to have their surgery on their clogged arteries, but they left the hospital completely normal neurologically. In the past, that was a rare instance for me, once every many years. Last year we had several, and I hope if it happens, we do that again. But please realize that last year probably was the exception. And if someone has an injury that's bad enough to stop their heart and stop their respirations, the likelihood of success is small, though we always try. So with that, good night to all of you. Like I said, Amy, if you and Kathleen could stay on just for a second, we'll say goodbye to everybody. I'm going to I'm going to get so I can wave. Let's see. Oh. So everybody else can leave unless you want to hear us talk about boring stuff. We're getting there. We're down to 6 people besides us.
Maybe people putting people to bed, or
Yes.
yeah.
Hey there, Chris. I didn't see you before that. Okay, there we go. At any rate, Amy, saved me a call. Just want to tell you, that was just awesome.
Thank
Really
you.
good job. And like I said, tell Johnny did a good job. The slides, the funny ones, the thing at the end, it was
Hi,
just,
Chris.
hey,
Sorry, I've been doing bath time with the kids all through the lecture, so I didn't even have a chance to push the leave button yet.
I need to ask one question though before you leave, Chris. Was that video
Yeah, what
from
do you
Deer
got?
Valley? Was that video from Deer Valley or elsewhere?
Oh, that was me in my rookie year.
There you go. Okay.
All right, you guys have a good evening.
You too. You too.
Have a good one,
See you
Chris.
later. Thanks, Amy.
Bye.
And bye.
Bye. And Kathleen, are you still there? Kathleen?
Maybe, maybe not.
Oh, are you there? Did you say something? I was going to tell her to turn the recording off, but I guess if we leave, it'll go off all by itself again. So I hope you're feeling good, because you should. That, like I said, that was really nice. I hope it was fun.
Yes, it was. I enjoy doing them.
Okay, well,
Thanks. Have a good night.
and I saw Ed in the background. Briefly tell him I said hello too.
I will.
Okay, bye now.